I'm Noel Boaz. My talk today is Phylogenetic Dissection of the Back, Anatomy with a Narrative. The back dissection can provide a prime opportunity to teach foundational anatomical concepts. This presentation is based on dissection of soft embalmed donors whose flexibility facilitates the separation of structures along natural fascial planes, thereby allowing homologous innervations and neurovascular patterns to be more easily comprehended. 9 structural themes or precepts are used to organize the dissections. Students can use this 9-piece toolbox to organize the roughly 500 names, terms, and concepts in this lab into a coherent whole. The 9-piece conceptual toolbox is organized bidirectionally. Read from left to right, it describes early to late embryological primordia, a narrative that is best presented in lecture or learned dialectically before laboratory. Read right to left, the 9 concepts describe superficial to deeper derivative structures that we will encounter as we proceed through the back dissection. All the muscles that we encounter after reflecting the skin of the back are extrinsic muscles, innervated by nerves with distant origins and migrated onto the back from above or from the sides. The first concept in our toolbox explains the trapezius muscle, a muscle inherited from our gill-breathing fish ancestors that pulls down cranial nerve 11 to innervate hypopharyngeal muscle fibers that develop from the same occipital somites that give rise to the tongue muscles anteriorly. The muscular neck elongates in mammals, bringing the caudal fibers of the trapezius muscle all the way down to the bottom of the thorax. Cranial nerve 11 is tested clinically by pressing down on the point of the shoulder against the patient's resistance. Much of the rest of the superficial back is covered by migrated upper limb muscles. These are primitive elevators of the limbs and develop from the dorsal half of the limb bud that we see here. Latissimus dorsi and the deltoid are the largest of these muscles. These muscles are innervated by ventral rami of spinal nerves, usually from the brachial plexus. Clinical signs such as winged scapula, result in cases of injury or compromise to nerve supply, in this case the long thoracic nerve, which can be cut accidentally in radical mastectomy. Our third precept covers the body wall muscles, also extrinsic to the back. 3 embryological layers of body wall muscle which have a plywood crossed fiber orientation, strengthen the body wall. In the thorax, the ribs secondarily grow in to separate these layers to form the intercostal muscles. Mammals then lose their lumbar ribs, bequeathing to us upright humans a propensity to herniation of structures in the abdomen through the body wall. Most hernias occur on the anterior abdominal wall, but lumbar hernias on the back do occur. The first 3 precepts of our toolbox can be reviewed and used to explain the 3 named clinical triangles of relatively light muscle cover of the back. The triangle of auscultation, shown in B, and the upper and lower triangles in the lumbar region, which are sites of lumbar hernia, shown in A and C. The back dissection is an excellent opportunity to establish a firm foundation for understanding the parts of spinal nerves and where they go. Spinal nerves have a dual embryological derivation, a dorsal root from neural crest cells with cell bodies located in the dorsal root ganglion, and a ventral root from axonal outgrowth from the neural tube. Just past the intervertebral foramen, the dorsal ramus separates off to supply sensory fibers to the paravertebral back and motor fibers to all intrinsic back muscles. Noel crest cells also join non-segmented mesoderm to form the spinal meninges. Ventral rami supply motor and sensory innervation to most of the back. A clinical correlation is the posterior surgical approach to the kidney, in which the two branches of the L1 spinal nerve, iliohypogastric and ilioinguinal, must be avoided. Although the sensory dermatomes retain the primitive pattern of segmentation of the somites, seen here on the left, there is significant myotomal fusion to form lengthened muscles in the intermediate and deep layers of muscles of the back. The serratus posterior muscles comprise the extrinsic intermediate layer and are largely vestigial back muscles inherited from thorax-breathing reptiles. The erector spinae muscles are long and semi-continuous intrinsic back muscles that have a general fiber direction that angles outward as they ascend, as does the splenius, cervicus, and capitis higher above them. Their function is to extend the vertebral column. The underlying transversus spinalis muscles are shorter, trend medially as they ascend, and act to laterally flex the vertebral column side to side with some slight extension. A clinical correlation that dramatically illustrates the pull of the intrinsic back muscles crossing multiple segments is the functional scoliosis that results from a unilateral compression of a spinal nerve secondary to a ruptured intervertebral disc. Embryological development of the sclerotomes within somites renders them intersegmental. That is, the caudal half of one sclerotome separates from its own cranial half and then fuses with the cranial half of the sclerotome inferior to it. Myotomes thus span the resulting intervertebral joint. After development of the vertebrae, growth of the vertebral column significantly outpaces that of the spinal cord, pulling the spinal nerve roots inferiorly into the cauda equina, surrounded by the lumbar cistern of cerebrospinal fluid internal to the arachnoid mater. Clinical correlation here is lumbar puncture and spinal tap. The deepest layer of transversalis muscles are the shortest back muscles. They cross only one or rarely two body segments. These intrinsic back muscles develop from single unfused myotomes and affect small-scale movements between adjacent vertebrae or between a vertebra and an adjacent rib. The suboccipital muscles are homologs, and they link the axis and atlas to the occipital bone of the skull, affecting rotational and extensional movements of the head at these joints. Clinical correlation is a surgical approach through the suboccipital triangle to approach the cisterna magna of cerebrospinal fluid. The spinal cord, originally unsegmented and open at both ends, develops from the round neural tube, a derivative of the flat neural plate. Contiguous developing mesodermal somites induce the neural tube to then form segments from which primordia of the ventral roots of spinal nerves develop. Numbering of spinal nerves begins with C1, the suboccipital nerve, and then changes at C7, when spinal nerve C8 exits inferior to the vertebra, a pattern of naming spinal nerves by their superjacent vertebrae that continues for the remaining segments of the vertebral column. Clinical correlates for this part of the laboratory include spina bifida and neural tube defects. The notochord, originally a cartilaginous rod underlying the neuroectoderm, undergoes degeneration during embryogenesis. Its derivative is the gelatinous nucleus pulposus at the center of the intervertebral joint. It is surrounded by mesoderm-derived annulus fibrosus. A posterolateral tear in the annulus fibrosus is the most frequent route of extrusion of the nucleus pulposus, causing spinal nerve compression. In summary, we have seen that the dissection of the back, if integratively presented with an ontophylogenetic approach, can effectively introduce important regional and systemic anatomical concepts that are foundational to the subject. Relevant clinical correlations are to be found at every step of the dissection. Thank you very much for your attention.